Hello, and thank you for joining the Pituitary Network Association's webinar program, which is brought to you through the support of our sponsors and our expert contributors. The PNA is dedicated to educating people with pituitary disorders, their families, and their healthcare providers. The PNA is a nonprofit organization that relies on the support from our members and donors. During the webinar, feel free to type in your questions at any time. Please note that all questions will be saved until the end of the webinar. We have allotted time to answer as many questions as possible. Today's webinar, Visual Recovery After Pituitary Surgery, is presented by Dr. James Chandler. Please hold as there will be a brief delay while we change presenters. Okay, Dr. Chandler.
Okay. Do you see my screen?
I sure do, yes.
Okay, great.
Thank you.
First off, good afternoon, late morning to everyone. I want to take the opportunity to thank the PNA for all that they do to enrich the lives of patients suffering from pituitary tumors and helping family members, caretakers on that particular journey. It's an honor to be a part of the organization and to participate. I think one of the most treacherous aspects of having a pituitary tumor is the risk of going blind. That's obviously nothing that anyone ever wants to experience. It's profoundly life-altering for the patient and everybody around the patient. And frequently I get questions around what about my vision. And so the objective today is to leave you better informed about exactly how pituitary tumors can cause blindness and what are the opportunities for improvement. Let's see if I can advance my slide. Apologize, I'm borrowing a computer, and so it may take me a moment or two periodically to adjust. And before I dive in, just want to add another note. The presentation is tailored for neurosurgeons, endocrinologists, as well as patients. And so with some of the slides, I will pare down some of the detail and just focus on the points most salient to this audience. So let's start off with a scenario that represents my comment during the introduction about concern about vision. This was a woman who came to me several years back. She was 80 and she had a 40-year history of blindness and essentially had an incidentally discovered pituitary tumor that was determined to be non-functional, meaning it was not overproducing any particular hormone. And she was having some memory issues, and her doctor obtained this study as part of a workup for dementia. Keep in mind, 40 years ago, we didn't have MRI, and CT had just recently been developed. She had been given a diagnosis to explain her blindness, which progressed over the course of a decade. And she came to me with this growth right here, and that is the pituitary growth. That's a pituitary adenoma above the pituitary sits the optic chiasm, which usually is a straight line like so. So this growth is bowing up into the optic chiasm, which is the structure where the two optic nerves meet and form somewhat of an X. So presumably this was compressing those optic nerves in the optic chiasm, causing her visual changes. And some of you patients on the line may have had a visual field study, and this is what a visual field exam looks like. Each eye is assessed, and the black means no vision. So you can see that there are little spots of gray on one side, the other completely black. But on examination, she really had no perception of light. And so, it begged the question. She had two important concerns. She said, I'm 80 years old. Should somebody 80 be having surgery? And will surgery work as well for me at 80 as somebody much younger? And then the other big question she had is, I've been blind for so long, and if this caused my blindness, and I've had all this pressure on my optic chiasm for all these years, is there any chance that I can get better? So I want to share a little video that kind of highlights this story. There we go. Is there no volume?
You think, how can you miss a building? Well, you can when you start to lose your sight. I went to an eye doctor and he said, you have tremendous eye strain and you should give your eyes a rest. I was about 34, 35 when I realized there was something seriously wrong with my eyes. I couldn't see bus numbers, couldn't make out details across the street, things you take for granted. I was scared to death. Eventually, I received the diagnosis of retinitis pigmentosus. I lived the last 4 decades as a blind person, with the usual ups and downs, but pretty successfully. I worked. I had a wonderful support system, wonderful, wonderful friends. Then one day, I noticed something else started to happen. If I sat down, I was asleep before my butt hit the chair. I couldn't remember things, especially numbers. I decided to tell my primary care physician about it, and she listened to me and sent me off to have an MRI. And about 2 days after my MRI, she called me. She said, you need to make an appointment with a neurosurgeon. She said, it looks like you have a tumor. I always used to say to myself, I can deal with being blind, but I don't think I can deal with anything else. And I found that somewhere I could deal with something else. Indeed, I did have a tumor.
Patricia's MRI revealed that she had a large tumor at the base of the skull that was impinging on her optic chiasm, which is where the two optic nerves come together. It looks suspicious for a pituitary adenoma.
It was so hard for me to comprehend because I didn't have any of the classic symptoms that Dr. Chandler talked with me about. Most people notice that they have this kind of tumor if they lose their sight. Well, I'd already lost my sight. I didn't feel sick, but I was faced with brain surgery, and it was pretty scary.
I told her that this was probably the source of her blindness and that we may have an option to bring back some of her vision. And Pat said, well, while I've already adjusted to being blind and I have no regrets, if I could see light just one more time, it would be worth it to me. And that's why we did the surgery.
You cannot believe that you can have such a serious diagnosis and that it can be treated. But here I was. I'm still alive 2 years later. And by removing the tumor, I can see.
It always amazes me the courage, the resilience that so many of my patients, in particular Patricia, have. And to hear that we somehow improved the quality of her life, made her life better. It's heartwarming and gratifying. It's why I do what I do.
To see Patricia's success, to see Patricia living well, now having seen some light, that's what we want to achieve at the Malnati Brain Tumor Institute. This is a team approach, a relentless approach. We try really to push the envelope. Have tomorrow's treatments available today. Come up with more innovative approaches for every single patient.
To be able to see anything, to enjoy the sun is wonderful. To say the sky is gray or look how dark it is outside, those are wonderful gifts. And I am eternally grateful to Dr. Chandler and to the Malnati Brain Tumor Institute. I am extremely grateful.
Okay, so this is the MRI after Patricia's surgery that shows the tumor is now gone. And you can see the chiasm here free of compression. And this was a surgery where I was uncertain of what the outcome would be, and we'll touch base on some of the literature around operating on patients who've already gone blind. And my hope is that after our discussion over the next 15-20 minutes, you can all answer the following questions. So following removal of pituitary tumor, what are the chances that the vision recovers? And the greatest chance that there's visual recovery is in which subgroup of patients. Does the size matter? Small, medium, large? Or does it not matter? And which of these is the most important predictor of how vision may recover after surgery? The size of the tumor, the age of the patient, the duration of the symptoms, how much vision that they've lost. So as many of you are aware, pituitary adenomas represent close to 15% of all primary brain tumors, and one of the most common brain tumors that occur. And on the MRI, you can see how they expand the skull base, and then they grow up in towards the brain, and they can cause visual impairment if there's pressure on the optic chiasm. It can cause hormonal issues. It can cause a reduction in production of certain hormones, or they can sometimes be responsible for an excess production of hormone, in addition to causing visual impairment. And they can cause an increased amount of pressure in the brain that can result in headaches and nausea. This was more tailored towards the neurosurgeons that might be online that demonstrate this structure that I've been discussing called the optic chiasm. And this slide really highlights the orientation of different fibers. So we say this is the right nerve, this is the left nerve. Each of these little lines represents elements of the retina, which receives the perception of light, and that light signal travels down the axons along the optic nerve. And here in the medial, or the center part of the optic nerve, and this X structure is the chiasm, are the fibers that control the peripheral vision, which is why classically, patients who have a pituitary tumor, and that tumor has come up and is putting pressure on the undersurface of this chiasm, in particular in this area, the peripheral vision will be the first to be affected. And then as the tumor enlarges and causes more compression on the chiasm and the nerves, the vision loss kind of extends inwards into what we call the nasal area. And then ultimately, like Patricia, a patient can go blind. And the blindness is not just a result of the pressure on the nerves, the axons that interrupt the signal flow, but also because of pressure on this intricate array of blood vessels that are around the optic nerve and the chiasm. And if the blood vessels are compromised, then that affects the oxygenation, nourishment that the axons and the tissues receive, and they can be impacted. And the vascular compromise tends to be a more significant issue than even the pressure from the tumor. And so, as I described, when these grow upwards and put pressure on that undersurface of the optic chiasm, the first thing that gets lost is the peripheral vision. All right? So again, dark means blindness, white means vision. And so if you were taking a look here at an image of San Francisco, you can see or Paris rather, big difference between the two, but you can see where the peripheral vision is lost. And what's interesting to me is many patients don't even realize that they've lost their peripheral vision. It's after they've had a car accident where they were changing lanes and didn't see another car, or they're having a routine ophthalmologic or optometrist evaluation, and the deficit is observed. And this particular deficit, peripheral vision loss, speaks to pressure on the optic chiasm, speaks to most likely a lesion of the pituitary gland, and that most commonly is the pituitary adenoma. So, as I say, many patients will have a vision deficit when diagnosed. Many times they don't even know it's happening. And so there's a concern about vision. The standard requirement, to confirm the diagnosis and preoperatively is to test the visual acuity. And again, an optometrist or an ophthalmologist can do that. And then what's called a visual field exam, where different lights are going off and you show where those lights are in your field, and it will generate the kind of vision map that I showed previously. And so now let's talk through what are some of the predictive factors for visual recovery. All right, one of the first things that I highlighted was, what about the duration of symptoms? And I won't go into the details of these different studies, but what they essentially suggest is that the shorter the duration of symptoms, the greater the likelihood that you could have vision recovery. And that vision recovery can be anywhere from going from being blind to having full visual return. Tomorrow will mark 2 weeks ago that I saw a patient in the emergency room who came in with bad headaches and a very large pituitary tumor, and there had been some hemorrhage into the pituitary tumor, a condition called apoplexy. And in that situation, patients notoriously have bad headaches, and some will have vision changes. And when there are vision changes, it's considered an urgent, if not emergent, neurosurgical situation. He had no vision changes, and so we sent him home and planned for him to see me in the office on an outpatient basis the next week. His wife brought him back in, saying his headaches were worse within 24 hours, and he'd actually gone blind. So the tumor had expanded or the hemorrhage had expanded a little bit more, cut off the blood supply to the optic chiasm and nerves, and that constituted an emergent situation. I took him to surgery on a Sunday, and he went from being blind to, when I saw him last week, or actually earlier this week, he had complete recovery of his vision. So the duration of symptoms is important. And what about size? In patients with these giant tumors, and these tumors can grow to be 3 to 4 times the size of the tumor that Patricia had, is there any difference in outcome? And all the studies would suggest that duration of symptom is a statistically significant, less than 0.01, statistically significant predictor of visual recovery, whereas tumor size was not statistically significant. And that is borne out in study after study. So time of visual impairment is important. Size does not appear to make too big a difference. What about age? You know, as Patricia asked me, I'm 80. Does it make sense to operate on me at 80? Wouldn't I do better if I was younger? Similarly, I won't go through all the details of these various studies, but they all seem to suggest that age makes no difference in outcome. Right? So age is not important. In fact, for many years, I had a philosophy that anyone 80 and older, I would never operate on. And, as people are living longer, I've been seeing more and more patients with pituitary adenomas in their 80s, some in their 90s. And I think to date, the oldest individual that I've operated on may have been 95. And the reason I did it is she was going blind from a pituitary tumor. And she said, I'm otherwise healthy. I've led a good life. But to be blind in my final years is my worst nightmare. If there's any chance that I can have any vision recovery, I'd rather do that. I'd rather be dead than be old and blind. And so I now will offer surgery to patients in this age group losing vision. Okay, and so what about the extent of visual recovery? Is there a chance that if somebody has lost most of their vision, can they get it all back? And, all the studies would suggest that visual recovery is somewhere between 65 and 100%. So surgery can be very effective. Again, I'm tailoring this more to the clinicians. This slide just reinforces what I said. And, I won't go through the details. So this is again demonstrating vision improvement at fairly significantly high rates, both visual acuity and the visual fields. This was a meta-analysis, meaning a collection of all existing medical literature on the subject. And so most patients will improve after surgery. And some of the key points are just elucidated here, which I already stated. One of the things I'll add is that, as with any type of surgery, the surgeon's experience also plays a significant role. The more you do of anything, the better you get at it, and the better you are at treating the patients. And then again, the duration of symptoms, where it seems fairly established that the visual recovery in patients who've had symptoms beyond a year tends to be less. So if I see someone who's losing vision from pituitary tumor, and we're trying to decide when to do the surgery, in general, I encourage them to do it sooner than later. There's some people who say, I have some time in the summer, 6 months from now, so maybe we can do it then. Well, if that takes you beyond the year mark, there's a precipitous drop in the chance for recovery. So in general, if you've had vision loss, you want to have your surgery within a year's time. This is a scientific study that I won't go into detail about. And, one of the things that's important is to obtain very comprehensive and sophisticated vision testing before surgery. And this article I won't go into detail about, but it basically highlights the importance of a technique called optical coherence tomography, which allows us to look in the back of the eye at the thickness of the retina and the what's termed the ganglion cell layer there. And if that layer is thick in a patient who is losing vision, the chance of a rapid recovery is greater than if that layer is thinner. And the thickness or thinness of that layer will be a function of the duration of the compression. So it can be a predictor of how somebody will respond to surgical intervention. So, if you're taking a loved one or if you're getting tested for vision, most places offer this technology, but if not, make sure they have the most sophisticated technology that exists to understand the nature of your vision loss. And this is just what it looks like with the ophthalmology in the ophthalmologist's office, where this is a very thinned out retinal layer, and you can see that more robust thickness here. And this is a patient whose vision after surgery is going to recover sooner. All right, what about going back to Patricia's case? If somebody comes in and they're blind, is there a role for surgery? Well, Patricia regained some light perception, but clearly did not have a what we call serviceable amount of vision recovery, where she could perform complex tasks with her degree of vision, as compared to the gentleman who had the apoplexy that I just described, who lost his vision, and within 24 hours, we took the pressure off, and he made a complete recovery. And all the medical literature would reflect basically that. And depending on the duration of the blindness, it will predict the degree to which someone's vision improves. So if we look at this chart, and this is showing that there's been a visual problem less than a month, 1 to 3 months, 3 to 6 months, etc., and then the visual improvement, and so 60% improved when it was less than a month. But if the vision loss was greater than 12 months, only 22% of patients improved. And if we look at patients who present with blindness, and this is in weeks, less than a week, like the case I presented, if it's less than a week, 100% of those patients will improve and have good vision, serviceable vision. Whereas if it's beyond a year, and in this particular study, no patients had any restoration of sight, and anywhere between 6 months to a year, there was only one patient, or 10% of patients in this study group, who had some recovery of vision. So Patricia was clearly an outlier. And if we go back to the original questions that I hope I answered through this brief discussion, following resection of a pituitary adenoma, the chances of vision recovery? Answer is 80 to 90%. And the greatest chance of visual recovery is in which subgroup of patients? And so this is going back to the size: small, medium, large. And this is a situation where size really doesn't matter. And which of these is the most important predictor of visual outcomes in patients with pituitary tumor? The size of the tumor, the age of the patient, the duration of symptoms, or the degree of visual loss? I hope I've made it clear that it's all about the duration of symptoms, and the sooner you get in to have the pressure moved up off the optic chiasm, the better your vision will be. So that concludes the didactic portion of this session, and I'm happy to field any questions.
Thank you so much, Dr. Chandler. We do have a couple questions that came in. The first one, it says, I was at 2 different hospitals to treat my tumor. After the first hospital and multiple surgeries, I still had my peripheral vision, but he didn't remove the tumor. The second hospital, the doctor did remove it, and that is when I lost my vision. Is it because of the removal or what? Is there ever a time that I can regain my lost sight?
Well, that's a very good question, and it's a scenario that we see from time to time. And I think that this is really a situation where when you take some of the pressure off the chiasm, so if you can get into a tumor, kind of core it out from the inside, that reduces the amount of pressure on the optic chiasm, the optic nerves, allows for better conduction of signal across the nerve and the chiasm, allows certain blood vessels to open up and feed the optic chiasm. And I presume that was a judgment call based on that surgeon's experience, meaning that sometimes if we go after that capsule that's right adjacent, interfacing with the nerve, those intricate little blood vessels that I showed you on the one slide, it's actually kind of a shared supply between the tumor capsule and the optic chiasm. So if we see that, we elect to leave that little cuff behind because you've taken the pressure off, and you stand the risk of devascularizing or injuring those blood vessels if you take that capsule off. And I would presume that the second surgery may have compromised some of those small little blood vessels that I showed that may have been shared between the tumor capsule and the optic chiasm. And to the question of recovery, I don't know how long it's been, but as I mentioned, when there's a injury or compromise to those little micro blood vessels, the chance of recovery is very low. One of the things that may be useful is to have that more sophisticated study that I mentioned, the OCT, the optical coherence tomography, where they can look at the retina and assess the degree of existing damage, and that could predict if there's any room for recovery.
Okay, thank you. The next question is, what is the visual outcome after medical treatment for prolactinoma?
It's a very good question. I recall seeing a patient early in my career who, like the gentleman from a couple of weeks ago, came in with the hemorrhage into a tumor and vision lost his peripheral vision, and the lab test showed that it was a prolactinoma. And I had scheduled him for surgery, and the endocrinologist at the time, who was a very senior endocrinologist, said, we can treat this with medical therapy. And I said, well, time is of the essence. We need to get the pressure off now. He said, all the recent literature would suggest that within days, these tumors can shrink on medical therapy. I was doubtful, but I allowed him to move forward with medical treatment, and the tumor did shrink, and the patient's vision did recover. So in many instances, yes. Having said that, there are a small subset of prolactinomas that are refractory to our medical therapies, be it bromocriptine or cabergoline, and would not wait beyond, say, 4 to 6 weeks of attempted medical therapy to intervene if somebody has ongoing and progressive vision loss. Because the longer that vision loss is present, the greater the probability that it becomes permanent. So I'll give them 4 to 6 weeks to try and shrink the tumor, improve the vision. If they can't, then I would recommend surgical intervention.
Okay, great. Thank you. And then our final question. Do other types of pituitary abnormalities affect vision, like my suspected arachnoid cyst that I'm having surgery for in 10 days?
Yes, there's several pathologies that happen in that area that can cause vision loss. I will say more commonly there's a condition called an empty cella syndrome, where there's a kind of a pulling down of the pituitary gland and stalk and optic chiasm, and that traction can result in some vision loss. Arachnoid cysts, for the most part, are congenital issues, and only a small percentage will grow and then begin to cause neurologic problems. So if you're in that small percentage, then that's a reasonable thing to do. If there's a chance that you have empty cella syndrome, which can mimic imaging an arachnoid cyst, the surgical strategy is different. It's not going in and decompressing the cyst. It's going in and elevating up the pituitary gland so there's not that traction. And so I would just be sure to ask the surgeon who's operating on you if they think there's a chance that you have an empty cella syndrome.
Okay, thank you. That's all the questions we have today. Dr. Chandler, we just want to thank you again for such a valuable presentation. I'm sorry.
I was going to say it's my pleasure, and I'm sure people will have our contact information. We have online presence to field questions. We have a 24-hour day hotline where you can call and have your questions answered. So there's more opportunities to answer more questions for anybody who didn't get a chance to today.
Awesome. Thank you so much. This will conclude today's webinar presentation. We appreciate you taking the time to join us. If you missed any part of this webinar, or if you would like to share it with family members or friends, it will be available on our website at www.pituitary.org. There will be a brief survey after the webinar. Please fill it out to help us provide you with the information you need. And thank you again for joining us, and enjoy the rest of your day. Thank you, Dr. Chandler.
Great, thank you.